a new standard of care, maybe not the standard of care, but a new standard of care is to do hypofractionated radiation therapy. Now, we can think about whether insurance companies will say it is the standard of care to go faster. But one thing that we talked about was when you go faster, there does seem to be this increased risk of GI side effects. You saw some slides potentially this morning that talks about that the area close to the prostate that we really as radiation oncologists worry about is the rectum. Rectal injury could be a bad thing, right? And you saw slides that probably look like the idea that if you could put something in between the rectum and the prostate, you would move the prostate away from it, and radiation falls off not by the distance, but the distance squared, right? So meaning if you could just move it a little bit away, the amount of radiation dose goes down significantly. We don't have to go too deep into the specifics of nuances of radiation. You're just trying to get it a little bit away so you can lower the radiation dose. So what is it? So this is a hydrogel spacer in which they created an FDA-cleared pegylated hydrogel implant that, there were some questions about maybe this earlier today, so I just want to highlight the specifics of some of those questions. So this composition is pegylated hydrogel. If you inject it with, you got a liquid here, it mixes in vivo. And in mixing in vivo, it then creates this gel which pushes the prostate away. But it doesn't last forever. It absorbs in about 6 months. So you're going to put it in, it's going to push the prostate into a different anatomic position, and then it's going to go away. It's visible on ultrasound, which is good. So when you're doing the procedure, you can see what you're doing. It's visible on MRI, which is good. So you can use that for treatment planning, as we see here. But it's really not greatly well seen on CT. So it's probably helpful if you're doing radiation work by getting an MRI and putting those pictures into your treatment planning. In fact, the seminal trial that got this approved mandated the use of MRIs. Now, this again is going to, if you're going to put it in there, it's going to remain in place, and then it's going to absorb and leave the body through the urine. So there was a question that asked, so this is hydrogel, it's hydrolyzed, goes into the kidneys, and it's excreted in your urine. That's how we get rid of it. So I want to ask the audience a question. I didn't make an ARS question, but it came up as we were talking about the biopsy question in transrectal versus transperineal. How many of you have the technology available to you to do transrectal biopsies? Everybody, right? How many of you, show of hands, have the technology to do transperineal work? So less than that. And so the question is, when one of the things that come up in that debate, pro or point counterpoint for whether you're doing the biopsies is, well, I don't have the tech. If I do the tech, I got to financially make it maybe reasonable to do this, right? Well, if there's another procedure that uses the technology, well, that would help to want to have that technology available to you. So this is a technology which is simple, quick, and available, can be done in the office setting. But remember, this is one where it's not transrectal, it's transperineal. So this procedure is one where if you're doing transperineal spacer placement, maybe you would do transperineal biopsy and vice versa. So how does this thing work? Well, the pivotal definitive external beam study showed safety, significant reduction in dose to the rectum with long-term clinical benefits. It was a randomized clinical trial that was spoken about earlier today, so I won't go too deep into it. But the key points of it is here. It was able to minimize the late rectal toxicity. So we couple our morning talk that I gave with respect to hypofractionation, which means that there's probably a slight increased risk by going faster with respect to rectal GI side effects. Now we have a way to decrease late rectal toxicity. In addition to reduced toxicity, patients experience long-term quality of life benefits. In 1 of 8 control patients, they had significant declines in the overall well-being in all 3 domains, bowel, urinary, sexual, compared to 0% of patients who were treated with a space OAR technique. There's been no previous prospective randomized trials of other technology and radiation therapy. That means IMRT, that means image guidance, that means, what's those $200 million things? Protons, right? Or stereotactic, that have ever identified an improvement in ED and sexual quality of life as compared to what we're seeing here. So this makes it interesting, right? This is why those 2 things, when I told you in 2018, this is a year of talking about making space. Space, meaning 1.3 centimeters, which is nothing, equals a 74% reduction in what we talk about as the dose that the rectum's getting, or the V70 was alluded to earlier. And that translates into a 75% reduction in late rectal toxicities. And you can extrapolate from that better quality of life with space OAR patients not experiencing any grade 2 or greater rectal toxicity, i.e. proctitis, rectal bleeding, fecal incontinence. So what I wanted to spend the next 10 minutes, though, is really about not so much where we were, but where we are and where it's going. Because as urologists, this is like, Raul had a really good question, and Dave had a really good question about other things that this might be used for when we're currently doing now. So now there's been over 27,000 procedures done in over 500 centers with 66 peer-reviewed publications, currently used in 19 of 20 U.S. cancer centers. And its emerging use is using it for all of these uses in radiation: external beam, brachy, proton, SBRT, combination therapy. So let's just look at the current clinical trials. My friend Rodney Ellis up at UH in Cleveland leads the NRG GU005 trial, which is a trial of hypofractionation, and space OAR is allowed in the same way rectal balloons are. The COMPARE trial, which is a trial of photon versus proton radiation therapy, space OAR is allowed in the same way rectal balloon is. So you can see from just an ongoing clinical trial development piece, we're really not testing whether the spacer it is going to be important. It's part and can be included in the clinical trial. So really what I want to spend the next 10 minutes on is, so what's the future? What does the future might hold? Well, in the pivotal U.S. trial, the inclusion criteria was as follows. It was T1, T2 patients with a Gleason score of less than or equal to 7 and a PSA of less than or equal to 20 and less than or 50% positive cores. That doesn't sound like high-risk patients, does it? And an MRI was mandated. Well, there's ongoing research to really go and interrogate groups outside of that inclusion criteria. So let's take a look at some of them. What about what I said before? Do you remember those words? Ultra hypofractionation, greater than 500 centigrades per day or more. And the POTENT-C study done at UT Southwestern, which is ongoing, randomizes as a multi-institution investigator-initiated study looking at the sexual quality of life of SABR, which is a sexy name for ultra hypofractionation, with or without neurovascular dose sparing. How about salvage post-prostatectomy radiation? Would that make sense? Well, these are the studies that have looked at it to date, the largest being a study with 69 patients. There were no grade 2 acute toxicity seen in that group, and 1 patient with a grade 2 toxicity at 6 months. Again, we're talking about in the entire world, this is the sum total of data on salvage post-prostatectomy, and clearly those in this room can help drive some of the future data in this space. Dave mentioned, I believe, cryotherapy when we talked earlier, and cryotherapy in a study of single institution 10-patient study looked at salvage cryo of the prostate at the University of South Carolina, and the feeling was that the use of SpaceDAR with prostatic cryoablation could provide a safe and effective modality for protecting rectal injury, and allowing for increased depth of penetration. How many of you, by show of hands, do cryo? So the answer is, if this is the sum total of literature on this, urologists are going to be the ones who are helping to drive the future of this hydrogel technology. And going forward from that, hydrogel technology could be applied to other organs throughout the body. And there's potential new indications besides what we're talking about here in the GU realm. Groups such as Augmentics have technology known as Tracelt. Tracelt is another hydrogel. This could be a model system for how spacers and these technologies continue to be built out. So when we look at this Tracelt, a little length on the cord here. This is similar hydrogel technology as SpaceOAR. Its composition, again, it's a pegylated hydrogel, which absorbs not in 3, but this absorbs in 7 months. Not in 6, apologies, my mistake, in 7 months. But the cool thing about this is it's actually visible not just on ultrasound and MRI, but it's also visible on CT and cone beam CT and mammograms if you were doing breast cancer. So its indication is it could be used in technology for a soft tissue marker and spacer. And it has approvals for FDA and some other things. And again, being able to be visible on things we use commonly like CT scan may make this a very, very interesting compound as we go forward. And its target uses could be in the bladder, right? So there's other things in the GU space we could use this for, such as bladder cancer. Could be used with respect to surgical planning and surgical management with respect to prostatectomy. And then outside the GU space could be in things like head and neck cancer, GYN, and there's a strong interest in improving outcomes in pancreas cancer. Clinical experience outside the United States is looking again at bladder marking clinical studies, and again in post-prostatectomy in Australia looking at using this to do urethral marking. And then in GYN, Brigham and Women's has also been using it with respect to some of the things that would sort of relate to us with respect to bladder. In conclusion, today I tried to bring to you a 10,000-foot overview of what's changing in the field of radiation oncology. We are probably transitioning to a world where your patients who go the route of radiation are going to start thinking about whether they want to do 9 weeks or they're going to go faster. The people you work with are going to have to come to terms with the fact that that will need for certain technologies to help facilitate that best and most optimally for your patients. As insurance companies and others start to tell us about here's the number of treatments people will be able to obtain, hydrogel spacing is equally and rapidly becoming a standard of care for prostate cancer radiotherapy with a growing adoption by the urology community. There's opportunities for those in this room because when we're really talking about this is a procedure in which needs to be done transperineally. And I'm a card-carrying radiation oncologist. I was a surgeon. Dave, I think, is not in the room now. But what I'll say is, if I had to have a sharp object in somebody's hand, I think I would put that sharp object in a urologist's hand over a radiation oncologist, except for a couple people we know. But in general, just societally, as a guy who is a fellowship-trained surgeon, I think my friends in urology are very, very well suited to help drive this piece of what we need to do to help radiation patients. So opportunities exist for the clinical investigation by urologists to look at things like post-prostatectomy and ablative technology. And ultimately, there are ways where, even if you don't practice these areas, know that as we treat other kinds of cancers, that hydrogel technology may be applied to other organs and make it both interesting in things we do, like bladder cancer, and other things that we don't exactly do, like pancreas cancer.